Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dykes. Today, I'm joined by Dr. Jim Marino. Thanks for joining us today, Jim.
It's my pleasure, Jeff.
So give us a little background about you're an orthopedic surgeon, now clinically retired, but you're into some other things as well. So why don't you take us back to how you got involved and started in orthopedics, how you got interested?
Okay, well, then we'd have to go back to about age 2.
Okay.
When I was 2 years of age, that would have been around 1956, end of 1955, I received an early Salk polio vaccine. And what many people, in fact, I'm sure the most doctors don't realize is that the Salk vaccine was not perfected for about 6 or 7 years. It had many, I'll just say, virtues in terms of ending the epidemics, but that was at the expense of essentially inoculating children with attenuated instead of killed virus. Mm-hmm. The Salk vaccine was supposed to be a killed virus. And so when they were preparing the vaccine, the viral particles, which had been grown in tissue culture, were placed in hot formaldehyde and stirred in large vats. What they didn't know was that some of the viral particles were clumping, and the viral particles that were on the interior of these clumps were insulated sufficiently from the hot formaldehyde to survive the treatment.
Wow.
And then, so it's a very long story, but they figured it out. It took a while. But for most people who actually were naturally infected with polio or who were infected through inoculation, the vast majority of people had mild upper respiratory tract infections, like a mild cold. Mm-hmm. Only in a small percentage did you have paralytic polio, which was the neurologic consequence of the virus as opposed to the primary gastrointestinal route. So even though the vaccine was not 100% effective because it was not a killed virus, it was very effective in ending the epidemics because everyone who was inoculated received essentially a low dose or attenuated viral inoculation, and the vast majority did not get any paralytic consequences. But about 50,000 Americans did get paralytic polio from the early Salk vaccine, and I was one of them. So I spent about 4 or 5 months rehabilitating in a hospital when I was 2 years old with bilateral lower extremity, basically paralysis at first, and then gradually paresis as I recovered. Mm-hmm. And walked with bilateral long leg braces and with upper extremity, supports, and eventually weaned myself off the braces with a lot of physical therapy and time, and was able to walk independently. But I've always been a limited ambulator. I've never been able to run, and I'm suffering now from post-polio syndrome, which has limited my walking ability and actually shortened my surgical career because I couldn't stand steadily for many years or for many hours at a time as a surgeon.
Yeah.
And in any event, at age 2, I was treated by very fine orthopedic surgeons, one in particular. I admired him, and he became a professional role model for me. And my parents, of course, encouraged me in my pursuit. So I knew I wanted to be an orthopedist in my very early youth and pursued that goal until it was achieved.
That's really interesting. I didn't know that about the vaccine. I think
Yes,
that might,
almost no one knows this.
yeah, that might get glossed over in the history books. So that's really
Yeah.
interesting. I mean, unfortunate, obviously, but really interesting. So,
Well,
um,
most people don't know, and I don't mean this to be too critical, but Jonas Salk was never inducted into the National Academy of Science. And, he's a Nobel Prize winner, so you would think it would be natural. But the
mhm.
reason he wasn't is because the the research community knew that he released released the vaccine under political pressure early, when the monkeys who were being inoculated with the vaccine and who were immunocompromised with steroids were dying from the vaccine. But in any event, that's what happened, and I became interested, obviously, in the field, and have been very fortunate to have been in it for many years.
Yeah. So talk about kind of where you went to school and residency and
Sure.
practice.
Sure. So I went to Tufts undergrad and did a double major in chemistry and biology, and finished in short time, finished in 3 years, and then went to Howard University in Washington, D.C., and finished in 3 years, and then entered my orthopedic internship and then orthopedic residency at University of California, San Diego.
Hmm.
Finished there, started in private practice, and did as much as I could as quickly as I could. I was a board certified orthopedist before age 30.
Wow. You're a
Yeah.
go-getter. Early,
Well,
early the whole way, huh?
I was anxious to get to where I wanted to go, so
Apparently,
I
why
didn't waste
waste
any
time?
time. Yeah.
Yeah. Shortcut. I'll take the shortcut. I'll get there faster than the rest of you guys. That's great. So then you practiced as a spine surgeon. You said you focused on
So
kind of lumbar spine.
yes, initially I was an orthopedic generalist. This was in the mid 80s, early 80s when I finished. And at that time, there were fellowships, but they were less common than they are now. And
Mhm.
I felt very well prepared to do general orthopedics. And in particular, I felt extremely prepared to do arthroscopic surgery because the arthroscopic techniques were evolving during my residency. And actually, many of the residents were better equipped to do arthroscopy than the attendings at UCSD, even though they were very, competent academicians. They were just, the field had been evolving at a rate that was rapid, and we learned a lot from community physicians as well as going to meetings. So I thought I was going to become an arthroscopic specialist in peripheral joints, knee, shoulder, elbow, etc., ankle.
Mhm.
But the patient population that came to my office was in large part suffering from low back pain or lumbosacral nerve compression from their lower back. And so I kind of realized that I had to modify my uh, practice orientation and even some of my training. And I did a lot of supplementation by going to spine meetings, joining the North American Spine Society. I basically went to as many spine meetings as I could and did as many hands-on courses with cadavers as I could to supplement my experience in spine during my residency. And that supplementation was focused on lumbar spine, so I excluded thoracic and cervical disorders
Sure.
from surgical treatment.
So I think there's a decent amount of crossover because the patients that I see, there's a huge number of peripheral neuropathy,
Sure.
and they come to me and they complain of symptomatic, foot pain, burning, numbness, tingling, whatever
Yes.
it may be. And then part of my job is to figure out, okay, what's causing that? Okay, is there diabetes? Do you have a history of back pain? Are there back issues?
Yes.
How do we evaluate that? So if you were talking to my audience, which is mainly foot and ankle
Yes.
people, what would you say to them in terms of getting them in for evaluation from a lumbar, What would you see
Okay.
on your end if I sent you someone that said, I thought, maybe they got some back involvement here, and is that causing their peripheral neuropathy?
Sure. Okay. So, like every musculoskeletal field, whether it's foot and ankle or spine, whether it's the axial spine or the appendicular spine or the appendicular skeleton, we want to know what are the aggravating, precipitating, and relieving symptoms, the conditions that make it feel better or worse. So many people with back disorders have no back pain. A lot do, but many don't. And so we want to understand is there a positional relationship between their dysesthesias, or is there pain in their feet and ankles constant? If they're recumbent and they have numbness and tingling in their feet, well, it's probably less likely it's coming from the spine. If it wakes them up at night, now we start to have to think about tumors, because generally speaking, the various degenerative conditions in the spine, which are typically degenerative disc or facet disorders, they don't cause pain at night, and they usually don't wake you up from your sleep. So you're just trying to go through essentially what causes your pain, what makes it better, what makes it worse, and of course, obviously, if they have back pain. And typically, you're looking for nerve root type patterns. If they're having diffuse dysesthesias in their feet and ankles, well, that's not as common or not as typical for a nerve root compression. It can be indicative of claudication or spinal stenosis. And in those cases, we want to know, of course, does it happen when you're standing and walking, and is it relieved with sitting? So there's actually a pretty quick way to exclude or start suspecting whether the spine is the cause of lower extremity dysesthesias. And obviously, after you get a good history, which is probably more important than anything, a physical exam to confirm your suspicions, nerve root stretch tests, postural tests, etc. Those are all helpful. So I really like spine because it's a bit of a decoding, if you will, what the symptoms are and what might be the underlying cause. Because if you get an x-ray of the spine in people over 45, a large percentage, you're going to have degenerative changes. If you get MRIs of asymptomatic people who have no symptoms at all, if you get MRIs, 30% are going to have disc diseases that would be diagnosed by a radiologist as herniations or protrusions. They're going to have degenerative profiles. They're going to have facet disease. So all of these findings, if they don't correlate with the patient's symptoms, can be misleading or completely unrelated to their symptoms. So the history is the most important thing, and I spent a lot of time with the history. That's where I found I got the most value, if you will, in determining the likely cause of the pain.
Sure. So if we had a patient who, on your end, would you be more likely to see someone who if they had bilateral issues, that it's more likely spine, or is it more likely if they're having unilateral issues? Because in my mind, if it's bilateral, it kind of keeps the door open for some other systemic causes. But if it's unilateral, that doesn't tend to be diabetes or something like that.
Well, absolutely. If it's unilateral, it's less likely to be a systemic, neuropathy. Absolutely. But of course, as you know, bilateral, lower extremity dysesthesias can occur with spinal stenosis, claudication, sometimes with a herniated disc, but quite unlikely, but possible. A large central disc herniation sometimes can produce bilateral symptoms, but it's uncommon. More likely, it's unilateral. But a lot of the degenerative processes occur at many levels, at multiple levels. And so you can have bilateral symptoms. They may not be in the same radicular pattern, but I agree. Bilateral symptoms, you're going to be thinking more systemic neuropathies.
Would you say that people with diabetes, so, I don't know if it's ever been proven to be true or not, but something called double crush syndrome.
Absolutely, yeah, sure.
So someone has, I'll just explain it to the listeners a little bit. So if someone has maybe an underlying systemic issue like diabetic peripheral neuropathy, maybe those nerves are a little more, for fragile, I guess, or predisposed to having some issues. Did you see that on your end?
Yes, yes,
Yeah.
it is it's found not only from systemic neuropathies but also from peripheral neuropathies. So, if somebody, for instance, has a cubital tunnel syndrome, which is compression of the ulnar nerve at the elbow, but
Mhm.
they also have a cervical neuropathy from disc herniations or degenerative changes in their neck. That can provoke a double crush syndrome, and one needs to go through a proper evaluation to make sure that it is not exclusively from the elbow. And of course, it can also occur with the median nerve at the wrist and carpal tunnel syndrome, and also can occur in the lower extremity. So, yeah, all of those things need to be taken into account when you're doing your evaluation.
So if you had someone that had some sort of lumbar disc disease or compression or something, and I'm not a spine surgeon, you
Yes.
decompressed or whatever,
Yes.
what would you say the resolution of their lower extremity neuropathy? Is it highly successful?
Okay, so this is really one of the great, I'll say, rewards of being a spine surgeon. You almost know instantaneously if you help them when it
Hmm.
came to peripheral, when it came to neuropathies or nerve compressions. If they didn't wake up in the recovery room with virtually complete relief of their neurologic symptoms, you worried. You missed
Hmm.
something. You didn't
Hmm.
adequately decompress them. Something I was one of the first people to do outpatient disc decompressions and, what we would refer to as a discectomy. And I did them because when I started, people were admitted the day before, the night before, and stayed for 1 or 2 days. But I was thinking, gosh, the people have almost no pain post-operatively. They were miserable and they were home for months before the surgery. Why do I have to keep them in the hospital? I mean, I can monitor them without them being in the hospital. So I started sending them home the day of the surgery. And initially, that was almost scandalous in the community. They thought I was being somewhat negligent.
Yeah.
And now it's standard of care because if you haven't relieved their radicular symptoms from nerve decompression at the time of surgery, and if they don't wake up in the recovery room dramatically better, something's wrong. You either missed the diagnosis, or you didn't do the surgery properly, or you crushed the nerve or compressed the nerve during the decompression.
Hmm.
And frequently prescribed Vicodin for patients postoperatively after a disc decompression or herniated disc procedure, and almost never did they fill the prescription. I told them, look, you can fill it, but probably you'll be fine on Tylenol. And it
Yeah.
was virtually never that they filled the prescription. It just wasn't needed.
Yeah. That's amazing. So pretty instantaneous.
Yes, almost. And with spinal stenosis, which is a condition in which you have basically venous congestion in the spine from narrowing of the spinal elements, the symptoms are provoked with posture, which is basically standing and walking and relieved with sitting. And again, if the patients on the first day post-operative couldn't stand and walk, without having their symptoms completely gone, I would worry that I missed the diagnosis, or I missed the procedure. I missed decompressing adequately. The experience is dramatic improvement in neurologic symptoms with proper decompression. The caveat is, if you're doing a decompression and fusion, the fusion portion of the procedure can be a painful portion of the operation, and post-operatively, until the fusion is affected, that can produce mechanical back pain, but
Sure.
it shouldn't produce nerve pain.
Sure. That makes
Nerve,
sense.
yeah.
So if I had someone that I suspected, obviously peripheral neuropathy, would you get more benefit from an EMG or a lumbar MRI, or do you utilize both of them?
Okay, so if I'm suspicious of basically a systematic neuropathy, and or I think it's peripheral neuropathy, I'm likely going to send him to a neurologist. I don't think an
Hmm.
orthopedist is a person for definitive diagnosis and or care for peripheral neuropathy.
Sure.
So, if I'm getting an MRI, I'm doing it for one of a few reasons. One is I've already made the diagnosis clinically from the standpoint of, okay, I know this patient has characteristic symptoms and findings for spinal stenosis or nerve compression and one of the lumbosacral discs, and I want to know if the level I think it is confirmed on MRI and what it looks like. That's when I'm ordering the MRI. I'm not ordering the MRI as an early diagnostic test. I should be able to figure out if their symptoms are consistent with a disc herniation or spinal stenosis without an MRI early on. And I'm only getting the MRI when I need to know what levels and what the pathology looks like when I'm going to operate. The other reason would be when my diagnostic impressions are confused. I don't, this doesn't sound characteristic. Is it possible they have a tumor? What's going on here? I really don't know what's going on, but I need some additional information. Then I'll order an MRI. The EMG nerve conduction studies, I used to request them from neurologists, but usually in concert with a neurology consult. So that's the way I used to work up my patients.
Sure. So in your practice, at some point you became involved in or had a passion for invention. So talk us through kind of how that came to be throughout the course of your career and why you enjoyed invention and patents.
Sure, I'll be glad to. Perhaps because of my experience with polio and my father being a physicist, my life was one of trying to make things work under various circumstances. So you had to be somewhat inventive. If you're going to be playing football with your friends and you can't run, you got to figure out, okay, how could I integrate in this game and be with my friends and make sure I'm not dragging everyone down. So I learned how to throw the football very well, and I played touch football. I never played tackle, but you have to be somewhat resourceful. And so I was always and felt always inventive. And even when I was in high school, I was doing some inventing of various kinds. But when as an orthopedist and graduated from my residency, I wanted to be an arthroscopist, a minimally invasive surgeon. And yet I was doing spine, and I thought, gosh, there must be a way, or there must be ways to take spine surgery to a less invasive form. And so I did a lot of thinking about that and realized that there would have to be instruments, tools, etc., techniques that would have to be developed. And that's really what started the earliest developments in the company I started called Nuvasive, which became a very, very successful spine company. Very successful.
And that's specifically geared around minimally invasive surgery is what you're talking about.
Yes.
So back at the time, were those just, because nowadays we hear all this stuff about MIS, at least in my world, foot and ankle world, everything is moving towards minimally invasive surgery.
Yes.
And I assume other fields of orthopedics, including spine, now it's commonplace. But back then, what were you doing then versus what you hoped to obtain? Like what size of incisions or what type of things were you trying to change?
In spine surgery, in order to get at the pathology with standard open techniques, we have to do a lot of muscle tendon stripping from the spine. Now, these are normal, healthy structures that we're damaging. We do a lot of what people refer to as collateral damage, just getting to the pathology.
Makes sense.
And the techniques for endoscopic spine were very rudimentary in the early days when I was starting to develop the ideas for invasive. And they didn't have development of nerve monitoring or the use of evoked EMGs to determine the relative position of the instruments that were going through small portals into the neuroforamen and into the disc space or into the foraminal space or epidural space. And I knew that, since you couldn't see except at the end of the scope, but you couldn't see a lot of things that were going on when the scope was being introduced, there would be value in evoking EMGs and having electrodes on cannulas and also having guidance, stereotaxic initially guidance, and as well as ultimately it's turned into computer-assisted navigation and even some robotics. But all this sort of had to gradually occur with the development of instrumentation and techniques. It's a lot has happened. I mean, I was the first person in the United States, and as far as I know, in the world, to do a trans-psoas approach to the lumbar spine, which was a minimally invasive retroperitoneal approach. And it's become one of the standards in surgical approaches to the spine without having to strip the muscles from the back. So anyway, there were a lot of developments that took place. And one of the developments that I felt was important was percutaneous bone harvesting. We were, at one time, we used to harvest the iliac crest bone by stripping, if you will, the periosteum and the attached muscles, decorticating, and then using curettes and gouges to remove cancellous bone. In the process, we created a lot of pain. And in fact, if you look at the older studies, which to this day influence surgeons, there was high levels of moderate to severe complications that lasted for sometimes many months, even years. So autologous bone harvesting was a source of continued postoperative discomfort and complicated procedures. So I wanted to find a way to harvest cancellous bone percutaneously.
Interesting. So what did you do about that? So obviously you have taken that to the next level, but why don't you tell the people listening what you did to kind of design that and develop that?
So in concert with some very fine engineering effort, and actually the president of our company, Jamil Elbana, is an engineer and was a very strong collaborator with me in developing a device we call the Corex device, which is a percutaneous, minimally invasive bone harvesting tool. And it's very applicable for foot and ankle surgeons because we can harvest bone from the calcaneus, the distal or the proximal tibia, or the iliac crest if your license allows. And it essentially, I have one here. It's a single patient use device. It comes in a sterile pack. There's obviously normally a Tyvek cover on this, which I removed. And the instrument, I'll try to back up a little so you can see it. The instrument consists of basically metal and plastic. It has a very sharp removable trocar tip, which allows you through a small incision to place this on the exposed subcutaneous cortical bone, and through oscillation, you can remove the cortex, but it has a shoulder stop so you don't penetrate too deeply. And then after you do your cortical fenestration or make your cortical hole, you then have a tool, I'm trying to show it here, which allows you to, it acts like a tree-fide, but it has an actuator or capture mechanism in one position, in the open position, where the black handle marker and the lower green marker are aligned. End of the tube is open. And when you rotate the handle just a quarter turn, where you have the black and red lined up, there's an inner tube which actually gets protruded and grips the bone so you can extract it. Then you open it again, and we have a tamp which you can use to then extrude the cancellous bone. And I can do a very quick demonstration on a simulator here. If you're able to see it, I'll try to make it as visible as possible. Yes, there's a 7 and a 9 millimeter. A lot of foot and ankle surgeons who don't need as much bone will use the 7 millimeter, but it works exactly the same way. So we have here a simulation block. Basically, this is dense foam to simulate cancellous bone, and on the top is a plate of hard plastic. And by oscillating back and forth, again, this is all done without seeing the bone, but just through feel. By rotating back and forth, I will create a hole in the cortex, and obviously on the calcaneus or proximal tibia, it'll be less hard. But once you reach a certain point where there's a loss of rotational resistance, without seeing it, you'll know you're on the shoulder stop, which keeps me from going too far. Then I'll just essentially remove the trocar tip, and then I'll use the tree fine first in the open position, go in, oscillating back and forth, and then I'm going to close the device, the capture mechanism, remove it, open it again, and then I'll use my tamp to deliver my cancellous bone. And you'll see the equivalent of this demonstration. The cancellous bone will come out with the architecture preserved, with the cellular content preserved in its normal physiologic location, which we think is a major advantage over techniques that involve suction, which removes the stem cells, and other techniques that involve morselizing the cancellous bone through small curettes. But you'll end up with an intact cylindrical cancellous bone for autografting that has all the mesenchymal cells in their normal position and with minimal architectural disruption. So anyway, that's our Corex device. We think it could be very applicable for many types of procedures in foot and ankle, and many hindfoot types of fusions. I'm
Absolutely.
a person who had a triple arthrodesis as a kid.
Oh, really?
And at age 12, and I'm still going pretty well on it, which is amazing given that I'm 71 years of age almost at this point. So yeah,
That's awesome.
It's held up very well considering all things. So anyway, that's the device that we're selling at Trinity Orthopedics now, and it's a bit of a promotion, if you will, on your podcast. But I hope your listeners will consider it because I do think it'll make their lives a lot easier in terms of harvesting, and they'll be, I think, very pleased with the amount of bone they can get, because we can go through the same hole on different directions and harvest multiple cylinders.
So I can think of a few issues that I've had with prototypical bone harvesting in the past, but what was it that you were struggling with the most? I think the idea that the trephine has a closure to grab the plug is probably the most beneficial part of that, because when I would make, say, a lateral window, cortical window in the lateral calcaneal body and go in, I'm just scooping and praying that something comes out. Oh, I got a little chunk of this. I got a little chunk of that. And it would be hard to extract it. The hole, fine, I got the hole. And then trying to extract the actual bone out of there is difficult. So what were you struggling with the most that made you think, okay, there's got to be a better way to do this?
Okay, so unlike your probably minimally invasive technique for harvesting from the calcaneus, when I was harvesting for spine procedures or for general orthopedic procedures, I was generally harvesting from the iliac crest, and it was an open technique, which involved, incising the aponeurotic attachment of the gluteal muscles and the lateral flank muscles from the top of the crest. Yep. I was then creating a cortical window, and then, it wasn't hard for me to recover the cancellous bone because I had, a big open technique, and I was using gouges and curettes under direct vision, and I could use a forceps to pluck it out. So the problem I was trying to solve was, how do I avoid this muscle and muscle stripping and decortication type procedure and make it much easier and quicker? And then after you do all that, you got to repair what you damaged as best you can, or certainly sew it back. And so that was the problem I was trying to solve.
I've seen patients before who complain of more donor site morbidity in their iliac crest than whatever the procedure that they were having done.
Yes, that is known, and was one of the reasons why allografts and BMP2 and a variety of other substitutes for autologous bone became commercially so successful. But even with their success, they lack some of the features that are associated with autologous cancellous bone. I think, for many surgeons who are looking for the optimal bone graft material, nothing exceeds autologous cancellous bone. If you harvest the cancellous bone in a manner that minimally disrupts the architecture and does not disturb the cellular elements within.
Yeah, I agree. So I think we could all agree that gold standard is autograft harvesting, as long as we can do that in a way that's simple and, like you said, decreases donor site morbidity. I struggle with other bone graft products for a couple of reasons. Number one, they tend to be very expensive. Number two, it feels like you're only getting a few of the beneficial components. Either you're getting osteoconductive without inductive, or osteoinductive without
Yes.
conductive, or you're using a structural tricortical graft, but you're having to soak it in PRP or BMA or something that's trying
Yes.
to bring it back to life. You're trying to reincarnate a dead chunk of bone and just hope that it doesn't stay a dead chunk of bone in there. Specifically, the people that are listening are doing hindfoot fusions, subtalar joint fusions, ankle joint fusions, tibiotalo-calcaneal joint fusions, where we need certain types of bone. But that's the difficult part, is when you're picking bone graft off the shelf, it's difficult to get most
All
of
the
those
features
to
you
be
want.
helpful. Yeah, exactly. And I think, at the end of the day, this is, way cheaper, because you're not paying however many $1,000 for a
Yes.
prepackaged, donated, lab grown product, which are
Well,
easy. No one's going to argue about the ease of that, but
yes. Yeah. We call it bone in a bottle. There's no
yeah.
question that the convenience of bone in a bottle is something that's very appealing.
Mm-hmm.
There's a lot of misrepresentations about the cellular-based matrices. These are the allografts that are supplemented with mesenchymal stem cells that are expanded in culture. The
Mm-hmm.
first part is there's a misconception that they're immunologically privileged.
Okay.
All the data, immunologically privileged, meaning they don't elicit an immune response.
Right.
All of the data that had supported that were in vitro, not in vivo data. When you look at the in vivo data, the mesenchymal stem cells will provoke both a humoral and a cellular immunologic response in animals. So this idea that they're immunologically privileged is a false concept. The other thing that's probably even more obvious but missed is that mesenchymal stem cells do not make bone. They have to transition into osteoblasts to make bone.
Mm-hmm.
And there's a couple of problems there. The first problem, getting back to immunologic status, osteoblasts are not immunologically privileged. So as soon as they transition, if they transition into osteoblasts, they become fairly high targets for the host environment to mount an immune response. So that's an important thing. The other thing is mesenchymal stem cells will become osteoblasts only under certain conditions, and these are not easily reproduced when you're transferring them as you do in some of these expensive cell-based matrices. And probably the way cell-based matrices work is the cells have nothing to do with it. It's the matrix. It's the
Mm-hmm.
DBM and the cancellous bone that's included that's allowing for the fusion.
Mm-hmm.
But because of the, I'll say, promotional hype, they can charge a lot of money, and I think it's an unfortunate waste of money. So I would say, if you're going to use bone in a bottle, I would stick to the basics: DBM and probably cancellous allograft in freeze dried form is probably as good as you're going to do from an allograft capacity, and it's not going to be excessively expensive and will likely work as well as any of these cell-based matrices.
Yeah, I think it can be overwhelming with the number of products that are on the market and what they claim to, be they ask, hey, do you want some hydroxyapatite, or do you want some, calcium phosphate? Like, I don't know. Bioactive glass. Like, I don't know. Like, does it
Yeah.
work? I don't know. I know this patient's bone is going to work, but I don't
Yeah.
know if
So
this thing.
we have 100 years plus, over 100 years of published clinical studies, mostly independent studies, not with commercial bias, that are supportive for using autologous cancellous bone in a variety of applications, whether it be trauma, tumors, fusions, etc. So we have abundant clinical information for over 100 years on autologous cancellous bone. We have virtually no virtually no data, clinical data, on these various allograft substitutes that are not sponsored by commercial entities. So I would be very wary about spending a lot of money there. I would keep it simple. If you're going to use bone in a bottle, keep it simple. Cancellous allograft, that's been freeze dried or lyophilized, and DBM. That would be, I think, a reasonable alternative if you don't want to harvest autologous cancellous bone. If you want optimum conditions for your bone proliferation, then you got to do cancellous bone harvesting. And I would recommend you do it in a minimally invasive and minimally disruptive manner so that you don't separate cellular elements or distort the matrix of the cancellous bone as much as possible.
So let's put autograft aside for a second, or at least
Yes.
bone harvesting autograft aside for a second. What are your thoughts on PRP, bone marrow aspirate, things like that? Do you think those are necessary, or do you think that
No.
is just kind of fluff on
No.
top?
Fluff.
Yeah.
Okay, so what are you trying to do? You're trying to introduce various cytokines to stimulate the host bone or the transferred bone to produce more bone. Okay, you're looking for basically various bone morphogenic proteins and endothelial growth factors, etc., to grow into your proposed fusion or whatever it is you're doing, fracture repair, etc. Well, guess what? If you have vascularized bone native to the site you're doing this procedure in, all you have to do is stimulate bleeding bone. You know, take off enough of the subchondral plate, or if you're doing a non-union, remove enough of the fibrocartilaginous pseudarthrosis and create channels of bleeding bone. Then you're going to get all of those stimulators from the site directly, and they'll populate the hematoma, and you don't need to harvest platelets or extract marrow content, which, by the way, contains very, very few mesenchymal stem cells. I mean, it's like less than a half of 1% that are mesenchymal stem cells, and you have to do it just right. If you pull it out with too much negative pressure, you're going to get blood. It's just not necessary. It's not proven to be effective, and you can find Cochrane studies on PRP, which I think show that it's not particularly effective.
Yeah,
And
I agree.
I wouldn't waste your time or your institution's money on doing that. You're going to get a lot of those elements that you're looking for just from the site that you're going to graft site if you just stimulate bleeding and allow the hematoma to help you in your healing process.
Yeah. PRP never made a whole lot of sense to me. We're going to take the patient's blood out, spin it down, and then put it back in. Like, what did we just do? We just took the patient's own blood out and put it back in. I understand that what they're trying to say is happening, but I agree with you. That was already in there. If we're doing proper joint prep or fracture repair and we're,
Yes.
stimulating vascular healing, that's why we do subchondral drilling and we remove
Absolutely.
the cartilage and we do all that. We break up the subchondral plate. The patient should have enough of those things already in there to allow healing. So I agree with you from that standpoint. So
Well, that's good.
Yeah, I'm not a big PRP guy. So one of the things that you had kind of mentioned was C-arm navigation and targeting. I'm not sure how you worded it, but why don't you talk about that a little bit more in terms of, did that go along with the MIS approach?
Yeah, so this is an area where I did some uh, really prototype development work, and we don't have a commercial product. But I always thought, well, you know what? The best way to see something deep under the soft tissue is through, in the operating room, is with the C-arm. And if we could just use the C-arm, not for just simply seeing, but for directing ourselves toward very specific targets along an axial alignment, it would have a virtue. And the same engineer, Jamil Albana, and I developed a C-arm targeting tool, which we developed a prototype for and tested, and it proved to be very accurate. But like many things, the kind of money we would need to turn it into a commercial product exceeded our capabilities.
Yeah.
And we also had to realize that we were competing against large entities that had already rolled out more or less MRI and CT based types of navigation techniques, which they were promoting heavily. And so we would be swimming against the tide, if you will, or
Sure.
against the prevailing marketing flow. And we decided to shelve that concept, and it remains something I'm interested in, but we're not at this time. We don't have a commercial product.
Sure. So anything else you want to touch on here?
I'm glad to talk about almost anything you think might be relevant to your audience. As I told you, at one time I loved doing proximal first metatarsal crescent osteotomies. I
That
have
was
no
your go-to,
idea.
huh?
I have no idea what you or your audience like to do for for the hallux valgus, and but I found that if I did a proximal metatarsal crescent osteotomy, I could do the vast majority of the deformity correction, do a little, medial bumpectomy, if you will, and not have to touch the intermetatarsal space at all. I didn't have to go in there and do any releases or anything, or, the capsule relaxed. And it just seemed to me that that was a very effective procedure. And if I had stayed in foot and ankle, I think I would have tried to have developed an MIS way of doing that, which probably already exists. But anyway, that's
A lot of things are headed towards MIS. Right now, a lot of MIS head procedures, MIS lapidus, things like that. So, but the crescentic was kind of a go-to for a while. It seems to go in phases. Scarf was popular for a while in Austin, and now you got these MIS systems. It just seems probably just like every other phase of medicine. It goes in waves, and what's the flavor of the week? And then we're going to move on, kind of like the bone products we talked about. What's the flavor of the week? What are people doing versus the tried and true? So a lot of variability out there. So I appreciate you joining me on this episode.
It's my pleasure. I thank you for having me. And I hope that some of the things I talked about with you were of interest and perhaps even of some educational value to your audience.
Yeah, absolutely. So if people wanted to reach out to you, where can they find you?
They can find me through the company that I founded called Trinity Orthopedics, LLC, Trinity Orthopedics. It's in San Diego, California. You can find our device online, the Corex, Corex, Corex device with Trinity Orthopedics, and the contact information is there. And it's, if you need to get something to me, I'll be glad to respond. Somebody at the company will let me know, and I'll try to respond as soon as I can. But we try to make our device available to everyone to try at no charge, so they can try it as a demonstration. And then we also try to make it affordable so that price is not the thing that prevents a surgeon from using it in their institution.
Absolutely.
Thank you.
Thanks again for joining me. I really appreciate your time.
Thank you very much.
Yep. Joining me, Dr. Jim Marino. Thanks for joining us on another episode of Paw Patrol with your host, Dr. Jeff Dykes. We'll see you next time.
Thank you.